Hello, welcome to everybody here and to those of you online. Good morning, good afternoon, good evening, wherever you might be in the world. Welcome to our event, Replenish or Perish, the way forward for global health partnerships. Thank you so much for taking time during this incredibly busy week and for joining us. My name is Ellen Roskam. I'm coordinating the International Geneva Global Health Platform, who's co-hosting this event today. And we're going to be talking about the super partnerships. So with the new round of funding replenishment ahead for Gavi and the Global Fund, now is really an opportune moment to discuss the politics, governance, and the future role of global health partnerships, and how international and regional global health organizations should adjust to remain fit for purpose in a rapidly changing multilateral environment. The recording of this event today will be available in 1 to 2 days on our website, ghplatform.org. There will be a Q&A later in the session. And for those of you online, please submit your questions in the chat box. We'll be following those. We don't want you to feel that you're not here with us. I'm delighted to introduce today our moderator, Katerini Storing, who's an associate professor at the University of Oslo's Center for Development and the Environment. Thank you, Katerini, and the floor is yours.
Thank you very much, Ellen. Good afternoon, everyone here in Geneva, and to those of you joining us online. We are delighted that the Graduate Institute is convening this event together with us from the University in Oslo, and we would like to thank you all for being here. And as Ellen said, both Gavi and the Global Fund will soon be holding their replenishment events. It'll be their last replenishments of the Sustainable Development Goal era. And it'll shortly be time to ask what comes next for global health and what role should these partnerships play in defining this future. Gavi and the Global Fund are, as most of you will know, the largest and most influential of the new partnerships that were established at the start of the MDG era, which is almost 25 years ago now. They really challenged the established ways of working through the World Health Organization and the traditional multilateral system. And they did so specifically by giving a seat at the decision-making table to commercial companies, to civil society organizations, and to philanthropic foundations, notably the Gates Foundation. And in doing so, they fundamentally reshaped global health governance around private sector principles like efficiency, innovation, a preference for technological solutions, and protection of intellectual property rights. Now, donors quickly embraced this model as an efficient way of channeling aid, and this led to a proliferation of global initiatives, funds, and product development partnerships focused on specific diseases and health challenges. And they're sometimes called public-private partnerships and other times global health initiatives, but they have this in common. Within 20 years, the partnership model had become ubiquitous, with the 5 largest ones joining forces in the Access to COVID-19 Tools Accelerator during the pandemic, in which Gavi led the effort to vaccinate the world through COVAX. But the pandemic also reignited old debates about how the partnerships are dominated by a handful of powerful donor agencies and the apparent conflict of interest arising from the inclusion of for-profit actors and mega-rich philanthropists into the formal institutions of global health governance. And in the aftermath of the pandemic, the so-called Lusaka agenda has reiterated past calls for better coordination between global health partnerships and for their greater alignment with national health plans and priorities. But others have rejected such calls for incremental change, asking for more radical reform or even for such organizations to be phased out altogether. So in this side event, we're going to delve into the heart of this debate with the experts who have been instrumental in shaping it. We're going to be asking, how should global health partnerships develop to remain fit for purpose? And what role should they play relative to the World Health Organization and emerging regional health organizations like the Africa CDC in the future global health governance architecture? And how can the WHO fulfill its constitutional mandate to, quote, act as the directing and coordinating authority on international health work within what has become such an incredibly complex institutional landscape? So this event comes out of a Norwegian Research Council funded project on new forms of public-private cooperation in global health. And I'm going to now invite my colleague on this project, international relations scholars Antoine de Benguy-Pouvaillet, to set the scene for the panel discussion that will follow. And as Antoine will show, an important premise for the discussion forward is to understand how partnerships have evolved into what are really very sophisticated global health organization with the power to shape the global health agenda. Thank you, Antoine.
Thank you very much, and good day, good morning, everyone. I'm really absolutely delighted to be here, and it's a great pleasure to be able to set the scene, basically, for this event. And so, basically, the aim of this my presentation is, before thinking of the way ahead, I wanted to just take a step back and look at what happened before, what happened the past 2 decades, and I want to highlight 3 main developments that occurred within the partnership model over the past 2 decades. The first one is that global health partnerships have bureaucratized, or they have become powerful organizations with important bureaucracies, and that has important implications for the way they work. The second one is that they expanded their mandates that were originally narrow designed, and the third one is that they increasingly cooperate with each other. And my argument today is that this development fundamentally changed the nature of this organization, and that has important consequences for their accountability. All right, so the first major development that I wanted to highlight is that they have become more bureaucratic. Global health partnerships have moved from being primarily a loose coalition of partners with independent organization, with a secretariat that works to coordinate them, and they have become independent organization with a secretariat that works both to implement its mission, but also seek to grow and advance its own interest. And so you can see that in several ways. The one key aspect, of course, of this is that their annual budget has grown astronomically. As you can see on this graph, the Gavi and the Global Fund more than tripled their annual budget in little more than a decade, from 2005 to 2015. And then their funding kind of plateaued before the pandemic hit, and then they received again $20 billion over 2 years. So really a tremendous step forward in terms of funding. The second element of this bureaucratization is that they have increased tremendously their staff. The first CEO of Gavi, a man called Ture Godal, led a team of 5 individuals working from a UNICEF basement to coordinate partners. When Julian Loeb-Levitt left the organization in 2010, the secretariat had grown to 25 individuals. But last year, when Seth Berkley left, it was 600. And this increase in staff has been cutting across all of the global health partnerships. So the Global Fund has now 1,300 staff, CEPI and FINE over 200, UNITAID 100. And some of them, like FINE, even have country offices, which were not initially planned for. Thirdly, the executive directors and CEOs of this organization have come to play an increasingly important role as public-facing figures for this organization. You would all recall Seth Berkley and Richard Hatchett, who became the faces of COVAX during the pandemic, or the recent interest in finding a replacement to Seth Berkley as head of Gavi. And so basically what I wanted to highlight in this process, to sum up, is that the global health partnerships have had more resources, more staff, more profiled CEOs, and that have made them powerful organizations capable of setting the agenda and shaping policy in ways that they were not able to before. And this raises questions about the governance of this organization and whether their boards are still in control of this organization or able to exercise the control they are supposed to do, given the growth of their secretariats. The second development that occurred the past 2 decades is that many of these organizations have seen their initially narrowly designed mandates expanding tremendously. And I wanted to take the example of Gavi, which was launched 25 years ago with the ambition to immunize the world's children. And as the organization developed, they have increasingly introduced new vaccines into their portfolio, some of them not targeting children, and I'm thinking about Ebola, COVID, or cholera, for instance. This is an issue that is becoming increasingly important with a prospective tuberculosis vaccine that would be primarily inoculated to adults. But Gavi also moved beyond procuring and distributing vaccines by working to strengthen health systems, or more specifically, funding immunization support systems, such as strengthening the cold chains or the health system data. The organization has, in 2019, become one of the co-leads of the Global Polio Eradication Program, and that same year also started to fund diagnostics for yellow fever. And so moving beyond vaccines, obviously. And then, of course, the big one, when the COVID pandemic hit, Gavi led the so-called largest vaccine rollout in history with COVAX that got over $17 billion of funding over 2 years to vaccinate the world against COVID. And this places Gavi in a very central position in designing and shaping the future of pandemic preparedness and response, especially because they have over $5 billion of unspent funds from the pandemic, a treasure that really gives them a lot of power to shape what might be happening moving forward. And so you see this journey from immunizing children to doing a lot more, and that was not necessarily foreseen. And lastly, I wanted to highlight that these organizations that have been often thought about as working in silos or, vertical programs, they still do that, but they work increasingly together, and they have done so since at least 2015, where a lot of efforts have been made to increase cooperation. One of the most obvious cooperation is the construction of a joint headquarters for many of these global health initiatives called the Geneva Health Campus that was inaugurated in 2018. And in this campus, in this building, you would find the Global Fund, Gavi, UNITAID, FIND, all of which played an important role in the pandemic response, but also Stop TB Partnership and World Bank Malaria. And since 2015, they've led a lot of pilot projects, small funding projects together. FIND receives a lot of its funding from UNITAID, Global Fund, and Gavi, for instance. So you have all of these links together. But during the pandemic, this cooperation really took up a step forward by being institutionalized, or at least partly institutionalized, through the Access to COVID-19 Tool Accelerator, and so also referred to as ACTE. And so with my colleague Catherine Storang and Felix Stein, we called ACTE a super PPP, or a super public-private partnership, because it brings together several global health partnerships and other global health organizations together into a loose institutional framework of an extreme complexity. And so we compared ACTE to a series of Russian dolls imbricated into one another with no clear lines of accountability. And basically the key issue when you think of inter-PPP cooperation amongst this organization, is that they are each accountable to their own board for the implementation of their own mission or their own strategy. There is no common accountability mechanisms for joint projects. So basically, our argument is that accountability is diluted, which is what happened during the pandemic. And we argue with colleagues that it's some of the reasons for why the global response to COVID didn't achieve its ambitious goal. It's not the only one, but there are some issues that can be connected to a lack of accountability or joint accountability. And moving forward, it might be wise to think of new ways to keep these partnerships accountable together. So a joint oversight or a coordination mechanism that goes beyond the traditional ways of being governed by their own boards. Otherwise, it's very difficult to ensure synergies and common accountability. All right, so this is what I wanted to highlight today. My presentation is based on a couple of papers that have been published. You have the reference here. As Katrine mentioned, it stems from a broader research project through which we published numerous papers and articles. So please do check out our website or profiles and research case on Google Scholar. You can read more about all of this. And happy to answer any questions or by email, just to get in touch now or later. Thank you.
Thank you, Antoine. Does this work? Yeah. Thank you, Antoine. Antoine will be available to answer any questions in the Q&A later on. But for now, I want to invite the speakers to the floor. I'm going to be inviting one after the other. And then we will open it up to a Q&A a little bit later. So I want to start by inviting Dr. Mercy Mwangangi to the floor, who was co-chair of the Future of Global Health Initiatives that culminated in the Lusaka agenda that I mentioned in my introductory remarks, and which I understand has been a hot topic in other events here in Geneva this week. Dr. Mangani, or Mercy, as I'm going to be calling her, is a medical doctor and health economist and former chief administrative secretary at Kenya's Ministry of Health. And she currently works for AMREF and has extensive experience in strategic health planning, for example, in the development of Kenya's primary healthcare strategy and its response to COVID-19. So, Mercy, I'd like to start by asking you to explain a little bit why we needed the Future of Global Health Initiatives agenda for those who are not familiar with it, and what the key takeaway findings of it were, recommendations of it were.
Sure. Thank you for that question, and thank you to the organizers for putting this together. The Lusaka agenda, which has featured, I think, in almost 4 sessions in this assembly, is a culmination of work that began about 14 to 18 months ago. And essentially right after, should I say, a wind down of ACTE, and once we were coasting in the COVID-19 pandemic, Kenya and Norway came together and essentially formed a committee, a steering group of sorts, that had the participation of different countries, as well as observers from WHO and the World Bank and UNICEF. And ideally, the big question or problem that we were solving for was learning from the COVID-19 pandemic and appreciating all the gains that have been made by GHIs. What does the future look like? And I think what was special about this process is there was no predetermined outcome. The idea was, can we bring countries together, and can we ask ourselves and dream of a future, and try and see, in terms of looking at governance structures, in terms of looking at the current problems that were there, in terms of duplication of resources, in terms of being very aware of the global political landscape, the geopolitics that were going on, what truly does the future of GHIs look like? And so the team set off with different pieces of work. These were ingrained in analytical piece that was done by a consortium of universities across the world. And then we got into political, should I say, stroke negotiating diplomacy phase, where we engaged multiple countries, including GHIs themselves, boards and secretariats. And we essentially landed at a space where we had 5 key strategic shifts. So when you hear about the Lusaka agenda, it's essentially 5 things. GHIs have a clear role, and the clear role should be to refocus towards their investments towards primary healthcare. Number 2 is that GHIs need to focus and find a way of playing their catalytic role when it comes to domestic resource mobilization. Number 3 is that we needed to ask ourselves, and I think Anton has done a very good job of setting the scene, do we actually have equity imperatives in all these health outcomes? If you look at the mandates that the GHIs had, and as we've had mandate expansion, have we lost some of those elements when it comes to health outcomes and the equity of those? Then we had, I liked, I'm just from the Global Health Campus, actually. I was meeting with the Gavi CEO, so right before this meeting, the Gavi CEO, the new Gavi CEO. And when we were getting into the campus, it's commendable that you do have a joint sort of infrastructural investment. And this was done 2, 3, 4 years ago. How much further can they extend this? And we've had these conversations with all those secretariats, actually, FIND, Gavi, UNITAID, Global Fund, and they've shared with us what they've been able to do in terms of bringing a common pot of money together for efficiency gains, and the building is one such representation. A lot of the ICT systems are shared in the back end, and that's great, but what's happening at country level? How is that translating on the ground, right, where the action is taking place? And so with these 5, and the last shift, of course, would be, mobilizing the power that the GHIs have when it comes to R&D and addressing market failures, health failures, policy failures in that space. And how do we actually have a joint approach to this? And I think one of the things through that journey, and it was a very long, interesting, at times tortuous journey. But where we landed, which was very helpful, is that Global Fund and Gavi actually now have a joint program of work around 4 items, particularly centered around health system strengthening and the malaria vaccine, etc. And that's great. And what we're doing right now as we try to, should I say, institutionalize the Lusaka agenda is how do we ensure that these shifts, together with this new joint program of work, actually leads into roadmaps of implementation at country level. And so where we are right now is good strides have been made, particularly at the African Union. Very soon you'll be seeing an introduction of this at the ministerial level of adoption of the Lusaka agenda, as well as a roadmap on what that would look like. We are in the process of trying to identify pathfinder countries who would truly demonstrate what the 5 shifts look like, and along with the One Health, One Budget. That story, I think we're all familiar with it. So there'll be pathfinder countries. What I'm also most pleased about is that the boards have actually taken ownership of this work and have agreed to have convenings that center around the Lusaka agenda, as well as the secretariats. But one thing I think that we need to be clear about is the Russian doll analogy. And when you mentioned that, I remembered some Russian dolls that I have somewhere. If we don't have some form of perhaps super Russian doll coordination mechanism, then we're still going to continue going round and round and round in circles. And the question has been then, who then comes in to form that mechanism? And, you know, part of the Lusaka agenda was really cementing around country voices and agencies as being catalysts of that mechanism. But I think it would be important as we continue with this discourse, as we continue to look at what implementation of the Lusaka agenda will be, as Antoine continues with his work, how are you going to be able to actually have strengthened country voices in governance structures that represent the world? And then now think about this super mega umbrella coordination mechanism. I think that's going to be the difficult thing to do. But if we win that, then I think we will have made a step forward. I'll stop here.
Okay, thank you very much, Mercy. I'm going to invite Dr. Anders Nordström to join us on the floor because he's uniquely well positioned, I think, to comment on some of these issues that Mercy has raised. Dr. Nordström is a medical doctor and former Swedish ambassador of global health, amongst many other things, and recently has headed the secretariat of the Independent Panel for Pandemic Preparedness and Response. But his engagement with the global health partnerships that we're discussing today is also very long-standing. He's been part of establishing, governing, and funding them in various leadership roles within the Global Fund, within the WHO, of which he was acting Director General at one point, and also within the Swedish International Agency for Development Cooperation. And finally, also as a board member of the Global Fund, Gavi, UNAIDS, and the Partnership for Maternal, Newborn, and Child Health. So, Anders, I want to ask you, when you look at these organizations, say the Global Fund, which you were part of creating, how much do you recognize of the partnership that you helped to establish more than 2 decades ago?
That's a good question. I was the interim executive director setting up the Global Fund, and in 2002, we were 23 staff. And I was telling Mercy, the design of the board, I still have the napkin, how we designed the board. That should be a board of directors. The first board of the Global Fund, when we established the Global Fund as an independent Swiss foundation, there were 3 people. I was the board chair. This was done on the 22nd of January. 28th of January, I appointed the real board of chairs, and then we resigned, the 3 of us. And the real board was a board of directors, individuals. We didn't have any constituencies at that time, and that was the whole idea. So to answer or to reflect a little bit on this, I think one needs to look back and understanding a little bit, or first I should say, if we look back and to see what those global partnerships have achieved, Gavi, the Global Fund mainly, but also some others, it's quite impressive. I mean, this relates very much to, if you still remember the MDG agenda, maternal child mortality, AIDS, TB, and malaria. We were starting at 20 million people losing their lives. Now we're down to 8. So big contributions here. But what I think we need to bring in here is to understand why this happened and why was what happened necessary to make it happen. The political economy of this. I mean, it would never have happened if Tore had not had the ears of the Prime Minister of Jens Stoltenberg at that time.
Tore Godal from Norway.
Yeah, Tore Godal from Norway. And Tore was extremely efficient and good to get the political ear. And politics is about showing action. And this is why this happened. Showing action, doing something different, doing something tangible. Gro Harlem Brundtland was successful in then negotiating the Global Fund to be for 3 diseases. The initial idea was for 1 disease, for HIV. But she was not successful making it a Global Health Fund. This happened in Okinawa in Japan. So I think one needs to understand that there is politics behind, and there are some rationale to politics. And if we're going to change this, and I'm going to come to some ideas in terms of what we can do in terms of changing, we need to understand where is the power behind. Because if we don't understand that the power is not with the Secretariat, it's not even with the board, it's with the governments that provide the funding. And we need to understand that and see where that is if we're going to change. I'm worried today about the lack of resources. I mean, the competitions now, the replenishment, that's the title of this meeting. There are too many competing for too little resources, and that's a big issue. We will lose, not just in terms of impact, but in terms of efficiency by spreading ourselves too thin. Second, I'm worried about that we are not getting it right when it comes to the epidemiology. You had the meeting here the other day about the global burden of disease. As I said, 20 million people now down to 8 million people losing their lives. On the same time, we have 18 million people losing their lives prematurely. They shouldn't lose their life because of non-communicable diseases. The global health partnerships community are not addressing that at all. So that's the second worry. The last worry is that all of those partnerships are basically focusing on the health sector. If we're really going to have an impact, I've been in 4 meetings now during those days on health and climate, we need to move beyond the health sector. So what to do? First, I mean, both get our epidemiology right, what is really affecting people's health, and if we're serious about health, we need to get the priorities right. Second, in terms of resources, time to move beyond aid. Domestic resources, increase, step up. There are plenty of resources. I was working in Sierra Leone as the head of the WHO country office, one of the poorest countries in the world. Are they? No. Sierra Leone is quite a rich country. Plenty of diamonds, plenty of rare minerals. Where is that money ending up? So, I mean, I think we need to get the agenda right in terms of what resources from where. And international system, what do we need to do? And you were talking a little bit about the building. I think we can simplify much more. Because if we see the global health initiatives, they are mainly about resources. Financial resources or resources in kind. The flow of resources then in cash, one can simplify that flow. We made a proposal some years back when we did the preparatory work for the IHP to have much of more of a joint platform for channeling funds for health systems. It never materialized, but I think that's still a good idea. The same thing for in kind. Working with the market, providing goods at reasonable prices. Either you provide them free, or you pay a bit, or you will have access to good prices where you have graduated. Global Fund and Gavi could join hands here in having one way of working around providing the goods. And finally, coordination. Yes, I would love to see WHO doing that. And I would love to see WHO doing that instead of getting into the supply business and financing business, because that's really the work of WHO. The organization we haven't spoken about who's actually doing this, that is UNAIDS. UNAIDS was created as a reform initiative to get the international system together. Here we have 12 organizations together. I launched an idea many years ago when we did a piece of work around the global health architecture, saying we need to transform UNAIDS to UN Health. The problem is my English is not brilliant, and my wife said that UN Health, that means unhealth. So that was not a good idea. But I think still we can learn from how we dealt with HIV in countries, with national AIDS commissions, how we brought the system together. And we still need that. And I think WHO could play a convening, coordinating role, but they need to do that. And they shouldn't do what I spoke about here on Sunday, getting too much into the supply business.
Thank you. I just want to ask you a follow-up question, because in a recent interview in Development Today, you talked about the need coming out of the COVID pandemic to decentralize the global health architecture. And of course, the organizations that were considered in the Lusaka agenda and that you've been talking about now are northern-based organizations. You warned in that interview against, quote, cementing the power of the Geneva-based institutions in favor of a bigger role for African actors. Do you want to elaborate on that?
I think, I mean, we saw that very much happening during the COVID pandemic, which was very positive, sort of how the African CDC grow in importance. And not just the African CDC, but also the African Union. So again, now the African Union is stepping up and say, enough is enough. We need to do this in a different way. I think that is extremely important to take both the political responsibility, so the future should not be a next Act A, but we should have global coordination, global negotiations, but we should have resources, procurement, distribution, organization at the regional level. And I think both Europe and Africa is very well suited. We see a new CDC now happening also for the Arab states. ASEAN is speaking about this. In the Americas, POW has done this for years. So I see much more of a regionalization of global health. But I know somebody else is going to speak about this later. In one of the articles you wrote about the decolonization and we need to sunset, I agree with that, but we still need to work together at the global level. But we need to redefine what that agenda is and how we do that. So we shouldn't give up. We shouldn't, I mean, we still need global cooperation. But a lot what we've spoken about here in terms of financial resources, they need to come from countries. And again, what I saw happening from the African continent, there were much more resources put at the table. There could be more resources put on the table from the African countries themselves. If that would happen, we would change the total power balance.
Mm-hmm. Thank you very much. Well, on that note, I think it's appropriate to invite to the floor Professor Justice Nomignon from the Africa Centers for Disease Control and Prevention, and he is also Professor of Health Economics at the University of Ghana. Welcome. Welcome, and nice to meet you. So you've recently stated, also in development today, you've asked really who stands to benefit from the power imbalances and what you have called collective dysfunctions of global health partnerships. So you talk about the Lusaka agenda and really imply that this is really a call for incremental change that we've heard before and that doesn't go far enough. And you propose a series of actions to donors, the first of which is to set a termination date for the global health partnerships. Can you explain to us why we need a termination date and what else is needed instead?
Thank you very much. Nice meeting all of you in person. So I come from Ghana, and we say that give praise to whom praise is due, right? So, I mean, we shouldn't shy away from the fact that these global health organizations have achieved something. But we should not also be patting ourselves on the back when the business is not done. The next, and for me, the most important question is, what could they have achieved? Given what they have, given the resources they have, what could they have achieved? Have they achieved that? And I think this is where, the issue is. And for us, in that paper, and I must admit that I wrote mainly as a professor rather than
yes, of course.
from Africa CDC on that, because, some of these views are quite sensitive. 3 key messages we put out. 1, it is not a business of global health organizations such as Global Fund and Gavi and others to be buying basic commodities for countries. That should not happen. The next question is, we like to set termination dates, well, at least to motivate us for MDGs. We had 2015. SGDs, we have when? 2030? So the global health community is not, the issue of termination dates are really not there. And I think they are there to motivate people to work towards a certain goal. Why do you set up a global fund and assume that perpetually the world will be fighting malaria, AIDS, and TB? That's a basic question, right? What do termination dates, and my co-author and I spend a lot of time actually debating when that termination date could be, and I know people are very... so the 2030 we put there was simply to say, okay, align with some global termination dates. But it's really to put out the conversation and to push the issues. Mm-hmm. If it is not 2030, when is it? I mean, it is important that we make these organizations accountable. Anders talked about the composition of the boards, and who really are these organizations accountable to? Who are they accountable to, and what can they do differently that they are not doing? So in that, that argument, we really call for setting determination that for any global health financing, organization, as a way to motivate them, but also as a way to not crowd out what the countries can do, because we think that our countries can do better, and this is where we were expecting a bit more. I know Mercy was very involved in the Lusaka agenda to be a bit more pushy and let our countries know that, look, it's time for you to take responsibility. No one should be buying commodities for you. You should not let, other people pay for commodities. Let us redirect some of these, global financing to the issues that really matter, the systems issues, the R&D. We've been talking about manufacturing. These are big things that no one wants to fund. But this, for us, is the job of such global, financing mechanisms, so that the basic commodities and the basic services would be left for the countries. That means sunsetting, but also sunrising, and getting countries to take advantage, not take advantage, but really take their place and be accountable.
Thank you very much. I think one of the major shifts that I mentioned at the start before you arrived that the global health partnerships have cemented is the idea that engaging the private sector in its broad definition is part of what governing means now. So there's no need to justify the inclusion of the private sector, but rather it's taken as a natural. And so when we talk about reducing the reliance on aid, one of the things that we see when looking at the new regional health organizations and efforts to mobilize funding is a growing reliance on private sector and including philanthropy in funding initiatives like the Africa Epidemics and Fund, etc. Is there a risk that we will be transferring our dependence on public development agencies in the global north to philanthropic foundations in Africa?
Yeah. And I guess when you talk about philanthropic foundations, you are talking about the global ones, no?
Well, not necessarily.
Country-based ones,
yes. Yeah. What are the issues for accountability for how policy is set, for example?
No, thanks for bringing up the issue of the Africa Epidemics Fund. And I don't know how many of us have actually heard about the fund. Yet, this is a fund that we all in global health should be interested in. It's like the Pandemic Fund for Africa. It was set up when the heads of state converted before the COVID-19 response fund, in which they contributed. Countries put in money into the response fund. The private sector put in money into the response fund. When they converted that to an Africa Epidemics Fund, the idea was to motivate countries to put in public money, but also motivate the private sector to put in money. And I think that, the important issue there is the mechanism that allows our countries to take responsibility, and that's what they took. They said, we don't need to rely on, global, because COVID-19 has shown we cannot rely on other people. Let's take responsibility and set up a fund where we as countries, by the way, African countries and other countries also contribute to global fund. They put money into the replenishment. What we haven't seen is the countries actually pledge to put in money into this fund that is meant for them. In any case, this fund is close to them. And it's managed by Africa CDC. That's the mandate. Cholera is devastating, huge populations in Central and Southern Africa now. Where is the time to actually send a proposal to a fund based in Washington, D.C. or Geneva? And I like what you said. In any case, why is the Global Fund sitting in Geneva and not in Nairobi? Why is the Global Fund not in Addis Ababa? Why should it be in Geneva? Because it gives a lot of power to, some of these, and I think it shifts. It's actually mind-boggling that we do not think about the cost structure of some of these funds. Because arguably it would be cheaper to be located in Nairobi or Addis Ababa than in Geneva. So what we are saying is that we are beginning to see an increasing desire of our member states to actually put in public money. And COVID-19, if you go to the WHO Health Expenditure Database, the large increases in spending during the heat of the pandemic actually came from countries, public spending, government spending, not private, not donor spending. So it may take time, but I think we need to acknowledge the baby steps and actually support them that countries are taking, responsibility and push them to take more responsibility.
Thank you so much. Just a quick follow-up question, because although you have called for the global health partnerships to be sunset, they are aiming for replenishment and will probably be around for a while longer. Gavi, for example, has claimed that it has done a lot to increase country ownership, participation in governance. Do you or others on the panel want to comment on that? Like, what has been done, and is it really moving in a meaningful direction?
Sure. I could take that. Steps have definitely been made in terms of trying to engage countries, and I'm just borrowing from some of the insights, both formal and informal, during the Lusaka agenda process. And when we talked to Global South countries, both in Africa and in Asia, these were some of the comments. So, and I remember this actually in Addis. There was a minister there who said, country X sits on the Gavi board, and when I have struggles with the Gavi board, I don't have time to call another minister to go lobby for me at the board level. So in essence, they don't represent me and my needs. Remember, different countries have disparate needs, right? So imagine a minister, the Ghanaian minister, sitting there, or his alternate, lobbying and negotiating for Kenya. That's going to be difficult to do, and that's essentially what is happening in the structuring of the boards. The second argument has been, a lot of debates between should we be in Geneva, should we be at country level, and if we're in Geneva, then shouldn't we be lean? But I think you've seen Antoine's slides, right? So you could be in Geneva, but are you being lean, truly, even in terms of staff costs? And increasingly now, a lot of conversations on how do you engage the civil society, and how do you engage them in a manner that would be, should I say, productive, both to governments, but also the GHIs. And increasingly, we've had structures that have already been formed by the Global Fund, particularly who've been more experienced, perhaps, in CSO engagement. And most recently, there's a lot of calls on how do you reach the last mile? How do you get to the zero-dose children? How do you get to the partially vaccinated? You need CSOs. And should Gavi perhaps waste time and resources defining that for themselves, or should they borrow from already existing models? And if they're going to borrow from already existing models, i.e. Global Fund, will they try to improve the inefficiencies that exist in those models? So a lot of interesting insights from countries. The general feel is that agency could be stronger. Countries could be better represented. Countries could have stronger voices. And, I think, having sat in the countryside and now on this side, the onus is both on the GHIs and countries. Countries do need to step up, and GHIs do need to provide that platform. Yeah.
All right, yes. Anush, you've been part of the boards of many of these organizations.
And I've actually been the vice chair of a CCM in a country as well.
Yes. Oh.
A couple of comments. Just one fact. The most expensive WHO office, if you compare Geneva and the regional offices, is in Kinshasa. At least during my time at WHO, that was the most costly location. But then I think there are other reasons why we shouldn't be in Geneva. But cost can be quite expensive in Africa as well. Second, around the issue around accountability on the board, I think that's a very interesting one. And that goes back to what I said, how we started the Global Fund. At that time, it was 23 board directors. Now it's expanded a bit, but most importantly, now it's become constituencies. The whole idea was that the UN was totally inefficient. That was where we started. So not the UN organization, not an organization where we had the UN set up with 194 member states. That was the idea originally. Then it has evolved, moving towards becoming more of a UN organization. But just to remember where we were coming from, and that was why the reason it was created as it was, because we saw, or people saw, the inefficiencies of the UN system at that time. So now we have a much more complicated situation. And also just to put my worry here is about WHO, because WHO is now in some way offering, saying that we are the organization where every member state have one vote. So we can take care also making sure that everybody has equal access now to the supplies or to the money. I think they're promising a bit too much. I'm worried about that. And again, even if I believe in the UN, but I'm not sure still that that's the best modality. On the money last, you asked about the private foundation and the philanthropy. I'm not so worried about their influence. There's a lot of talk about the Gates Foundation and what they're doing. I've never seen them really interfering. And there are many other foundations. The African CDC, they got a huge grant from the MasterCard Foundation. That was really, and I think was extremely helpful, very good. But I think one needs to also get the perspective in terms of, as you were saying, in terms of, it shouldn't be that Gavi is buying the vaccines or the Global Fund buying the bed nets. That should be done at the country level. That's where the money needs to be. It needs to be national money, national domestic money. In Sweden, we have a tax burden of 50%, Nigeria 15%. You can increase tax. And as I was saying about Sierra Leone, you can get the income from the diamonds to flow through the government instead of somewhere else. So I think the solution is not creating a regional fund with that same kind of money and then you're applying for that. The solution is that we need to have domestic resources. We need to increase the tax basis in countries so that countries can pay. And there is risk. There are more resources than we are recognizing today. And so I think that's the future rather. I'm not so worried about the philanthropy, and I think they're doing quite a good job. But we need to also see the magnitude of what's the relative importance of those resources compared both to what is already available at the national level, but also what could be available at the national level. I think that's where we should go.
So if I understand correctly, you're saying we shouldn't be replicating the partnership model at the country level or at the regional level, but rather increasing tax base and public financing.
Absolutely. Yes. Then at what also was what Stephen said about R&D, that we should spend global money rather on R&D, for instance. I think, again, we should move beyond the aid paradigm. I was tweeting about this the other day, that to finance that kind of function, those are global common goods or global public goods. So there is also some discussion around global public investment, but that is not aid. I mean, we pay for a global system for how we manage aircrafts, air aviation, security today. All countries pay for that. We have a global financial facility in terms of getting the stability in terms of the financial market after the economic crisis. All ministers of finance pay for that. And we should get into the same mood and way of also paying for global health.
I'm just going to jump in there because he's mentioned the Ministry of Finance and share one of the experiences we had in Kenya. As long as, there's no sunset clause, as long as there's amorphous transition plans and amorphous graduation plans, the Ministry of Finance will not move. I have sat across the table from the PS in the Ministry of Finance saying, this is Kenya's donor transition plan. Can you get these resources ready? And they've asked me, are the resources still there? Yes. Okay, great. Continue. When the time comes, then we'll have this discussion. And we need to be aware of that incentive structure and the malformations in it.
So back to what Professor Nomia was saying about the motivating factor of it. Can I move on a little bit to the World Health Organization? Because it's sort of a paradox that when we talk about the global health partnerships, we rarely mention the role of the WHO. And of course, the WHO is sometimes a member of these partnerships. Sometimes it's an observer on their board. Sometimes it's a recipient of funding. For example, we know that Gavi is a major funder of the World Health Organization. But it's rarely in the driving seat when it comes to the governance of the partnerships. So I'm wondering, given what Antoine presented and what we've been talking about, can and should the WHO try to fulfill its constitutional mandate to act as the directing and coordinating authority on international health work? Should it, for example, develop an accountability mechanisms that engages all the global health partnerships through the World Health Assembly or something of that kind? What are your thoughts on that?
No.
Okay, no.
Well,
depending on the construct.
Okay, and and then I'll let you elaborate.
I will try to wisely move away from this question because,
No.
Obviously because of where I'm coming from. I mean, there's the notion of the Africa CDC, WHO. But I would say that it should be countries who will be driving this, not, ultimately it should be countries. I mean, the real question, and this is why I go back to the issue of the foundations and the private sector organizations. For me, the real question is who is driving the agenda? It is possible, at least from my experience at the CDC over the past 3 years, setting up a new program and getting partners to support. It is completely possible to get funding from other people, yet you drive the agenda. And I think this is what we want to get. We want countries to be in the driving seat. I mean, and let me just finish with a question that, from what Anders said. Should we be setting up another organization to take care of a dysfunctional system or an inefficient UN-like system? That really is the question. We don't need any more. In fact, we need to collapse some of what exists
Sure,
to solve some of those problems.
Sure, but the Lusaka agenda talks about the mutual accountability of the global health partnerships before their sunset, mind you. What can we expect them to hold each other mutually accountable, and who are they accountable to? Is it just to recipient countries? Is it to the taxpayer and donor agencies, to the philanthropies? It's how do we ensure that they are mutually accountable, and what role, if any, should the member state organization for health, the WHO, play in that?
Wow. I'm also trying to see how I diplomatically answer this. In some of the discourse, in getting to the Lusaka agenda, I remember some of the GHI secretariats sharing with us that the accountability matrix is complex, and that final accountability is actually to members of Congress and assemblies in donor countries. So think about that, right? So it's not just the board that you see there. It's not just the secretariat. It's not just the recipient implementing countries. It's not just the donor partner countries. There is another political layer of accountability. And we hardly ever talk about it. And I think in comes the question then, how would WHO manage that? Or Africa CDC?
Yes,
Right.
Anish. Thank you, Mercy.
I think in some way there is one legal aspect for this, of course. I mean, who is actually providing the resources, who are you reporting back, who's auditing you, and that should be crystal clear. Then there is another agenda, which is more in terms of being accountable for what results you achieve, and what Stephen was saying in terms of have we achieved maximum from the resources we have invested. I don't think so. So have a good matrix in terms of what we are actually achieving and being transparent with that. I think that's a powerful way. I do not, and that was why I said no to the question. It was not so much about WHO, but more, can we have a global mega governance structure? I don't believe in that. I mean, first we have tried different ways. I mean, the Lusaka agenda, a lot of appreciation for what you're trying. But we have tried it before. I mean, when we did the IHP some years back, I was at Downing Street and we launched the IHP. We set up the H8 group of health agencies. We had meetings when then Jim Kim was the president of the World Bank. We got high-level engagement of everybody committed. Did it happen? No. So I think, again, I'm going back to where I started around the political economy. Who's actually behind? Who's driving? Who's got the power? Can we leverage more now the power from Ghana, from Kenya, and what is happening now, asking from the African Union, saying this is enough? I think that's why we should focus.
Thank you so much. But I think understanding who has the power requires transparency, right? And I think, we've spent some time now discussing some of the challenges related to the global health partnerships. And ideally, of course, the partnerships themselves should be part of this conversation. In the lead up to this event, we sent 6 separate emails to Gavi asking for any representative of their leadership to join us in today's discussion. And they did not initially reply, and by the time they declined, it was too late to invite anyone else. And we have seen, the biggest global health partnerships are routinely ranked as being very transparent. They publish their board minutes and strategic documents, et cetera, on their websites. Yet we know that researchers like us, civil society organizations, and even journalists struggle to get frank answers from them to understand how they work. And we know even board members, Anders, you've spoken about this in the media, have stated that they struggle to gain oversight of the financial situation of these kinds of organizations. So how can we maintain trust in them as they transition towards greater alignment and country ownership? And does this lack of transparency suggest that they have become too powerful?
I will start by actually shifting the heat away from the GHIs. So who should be transparent? Is it just the GHIs or other people? I mean, as an economist, I've actually openly disagreed with some, not all, and I'm not referring to the recently launched investment case, but I have disagreed with the way that some researchers have actually conducted some of the investment cases for some of these, GHIs or funding mechanisms. I've openly disagreed on some of them with respect to the methods and the attribution. If someone gave you money, and perhaps because you want more money, you tell them that, oh, actually, your money is saving 500 million lives, when in fact, some of those lives saved could be attributed to other things other than the money that was saved. I mean, a very huge one, I won't mention the name, but I openly said, look, you actually are telling this funder that they have achieved what they have not achieved because of the methods you are using. And who is not being transparent here? I think it's the researcher. It's me who is the researcher. Because we need to not shy away from the fact that some of this, and we actually sometimes behave that all the funding on everything that goes on, from getting the vaccines to the vaccines reaching the child, from all the commodities being reached, is coming from Gavi or Global Fund. But it's not. Governments are putting in money in terms of staffing. But when we develop these, investment cases, we say, oh, your funding has given us so much. So again, it comes back to the question of the political economy. And I think we do not clearly understand what that political economy is. Of course, the GHIs can try to be as open as possible. And I sit on a few evaluation committees of some of the GHIs. And I know the struggle that sometimes we need to go through to say, look, in evaluating this particular funding mechanism, you actually need to go to the ground and talk to the country, the person sitting in the Ministry of Health. You shouldn't be going to the country and talking to the person sitting in your office within the country, because you are not getting the right, persons to talk to. So I guess transparency, is an elephant that itself needs to be, dissected and see. All of us contribute to that big elephant.
For sure. I just want to go back to what Mercy said about different lines of accountability and the accountability, for example, towards donor agencies. We know that some donor agencies have signed non-disclosure agreements with the public-private partnerships. And this is, of course, makes it a challenge for the public in those countries to exercise any sort of influence over the process.
Yeah, we've actually, in my tenure, I do remember sitting in front of a parliamentary health committee and getting questions on what we term as off-budget resources. And I remember the ministerial team sort of acting like, why are you asking us about this? This is off budget. You haven't appropriated it as parliament. And I remember thinking, but this is the opportunity, right? As a level of accountability. If, however strong or weak or robust accountability mechanisms may be in country, I think there may have been intentional blindness in recognizing some of these structures in the country and the role that they would actually support in accountability. If all these partners, including countries, GHIs, would sit and appreciate some of those mechanisms in country, those would unpack certain layers of transparency as well. So I agree with Justice. This is sort of very multi-pronged. And maybe the bigger question is, where are the incentives as to why the system is the way it is, right?
Yeah.
Remember, there is also a private sector player in the darkness, here in the shadow. What's going on there?
Yeah.
Right, so, yeah.
Yes, Anders, actually is shaking your head.
No, I agree. But also, if you look at the country level, there are incentives for putting your hands on the resources, both legal and unlegal way of doing that. So, I mean, there are a lot more need for transparency. But just a couple of comments on transparency, because you're thinking about Gavi, and we were struggling really to get the figures then from Gavi during the COVID pandemic, where one established then the COVAX, you had an AMC mechanism, you used the IFE mechanism. It was extremely difficult to understand what money actually had been made available, how much had been used, how much been committed, etc. I hope, and I think that is now being solved, but we were struggling at that time, and as a board member at that time, or part of a board constituency, we were quite frustrated that we couldn't get the figures. But I mean, what I'm picking up now, hopefully that will improve. But can I give you a couple of other examples of where
Yes,
I would
please.
like to see more transparency. One thing, and I see Carol sitting there, what I was fighting for years, but I gave up in terms of the Global Fund, was that the board of the Global Fund should actually discuss the yearly results report. I mean, for business, that's one of your core work as a board. You should agree, you should approve the annual report. That is not happening with the Global Fund. You approve the annual financial statements. There's no link in between where you spent the money and the annual report. So in the annual report, there are no financial figures, and the annual report is very, very good, actually, but the board is not approving or discussing it. And I was fighting for this for years. No one was interested, including the board. So that is something that the board potentially could do, because then we can discuss the efficiency, effectiveness of the use of the money. WHO launched their investment case now just the other day, asking for 11 billion. For coming from assessed contributions, and then they need another 7. Is that the whole story? No. If you look back and read the WHO financial reports from past, they also have a budget that they called emergencies, which then they have in the budget 1 billion. In reality, they raise 3 billion. So if you then are going to look what WHO is actually doing, now they're talking only about the base program. The big, what WHO is doing today is becoming a supplies and emergency organization. That we don't speak about, because that we don't know whether it will happen or not, and because of that we can't speak about it. And the last example then from UNAIDS. UNAIDS being a co-sponsored program, and the PCB, they speak about the joint budget, the core budget, what is called the UPRAF. I don't remember what it stands for any longer. But they never spoke about what the co-sponsors are spending on HIV/AIDS. And I remember at my time at the peak, then the UBRAF was 400 million. And we knew that the total budget of what the co-sponsors were spending and where they should get efficiency by working together was 10 times as much, 4 billion. Transparency, because then the co-sponsors, they were not prepared to share the figures or to discuss that at the PCB. So, I mean, I think there are a number of examples where you could, and all of this could be, it should be about, can we achieve better health results? By knowing what we have and talking about what we achieve.
But, you know, at the end of the day, why don't the global health partnerships engage in critical public discussions about their operations? Like, why are they not here?
It's a responsibility of the board. The board members. It's absolutely responsible. It's not, I mean, the secretariat should be helpful, but ultimately it's the board.
Right, but they sent nobody. Okay. Okay, I think we're going to open it up to questions now. We have, I think, about half an hour left, and we're going to be taking questions both from those of you in the room and from those of you online. Is there anyone in the room who would like to ask a question? Yes, I see at least 4 men with their hands. So we're going to we're going to take 3 questions in the first instance. So here, here, and here, please.
Thank you.
And please be brief so that we have time to answer them.
My name is George Akarishvili. I was at the Global Fund for 15 years until recently, so I saw its evolution from less than 100 people to over 800. And thank you, Antoine, for sharing your 3 observations. You spoke about broadened mandates, about increased sizes, and improved coordination, and I fully agree with the first 2. And I think there is a correlation between them, because as broader the mandate, as more people they need. But I'm less enthusiastic about the improved coordination, and health system strengthening is a good example, actually, because both the Global Fund and Gavi institutionalized health system strengthening about 15 or so years ago. And when they did it, they realized that at the country level, there is only one health system, so they were both working with the same. And they tried to coordinate, and they went as far as trying to create a joint health systems funding platform, which for various reasons didn't work. And even now, as Mercy mentioned, how coordination works at the country level and how it looks in Geneva is very different. So Andrew spoke about the influence of politics, and I agree that politics is influential at high strategic level. How these 2 organizations started the HSS was because they received encouragement from their boards. But as soon as the strategic decision was made, so both organizations started the HSS, the political follow-up stopped. So the boards were not engaged in following up how health system strengthening is operationalized, explaining this by the notion that the board should not be micromanaging the secretariat, which is true. But at the same time, without the influence, the operationalization was suboptimal, to say the least. So I'm just wondering if the panel members could elaborate on how they see the role of replenishment, which is upcoming at both institutions, as an instrument for influencing operational implementation of strategic decisions. For example, by telling the both secretariats that we are willing to fund you if you improve, for example, how you coordinate HSS at the country level, or if there are any other instruments for influencing the operational decisions without micromanaging the secretariats. Thank you.
Thank you very much. We'll take the other two questions now and then do another round later. Yeah.
Thank you. I'm Francisco Tongana from Africa Public Health Foundation. I'm a member of the council, which is a sort of a board of the Africa Public Health Foundation. So just a quick introduction. The Africa Public Health Foundation is a foundation created by Africa CDC to provide a partnership platform and raise resources for Africa CDC. Well, I have two issues. It was one important point which was raised by one of the speakers, I think it was Mercy, regarding the representativeness on the board. This is a major challenge. If I call my years back, I served on the Gavi board, I served on the Global Fund board, we had this issue. I have one concrete suggestion. Will not be possible to get 100% satisfaction from all the countries. What we did in the past was to use the major gatherings, like the regional committees, some space in the World Health Assembly, to get the constituencies together amongst ourselves as ministers of health and to ascertain ideas before we go to the board. But that coincidence of preceding the board meetings with the regional committee or the World Health Assembly cannot happen often. So you always have the gap. So my suggestion is that whatever gathering where you get most of the ministers there, use that opportunity to consult each other before the representative going to the board. There was another important question. I found it quite pertinent and timely. Where the money should be used, if we have additional money or the existing money. Locally, absolutely. If I take the case of Africa, there is major work now underway. There is good initiative from Africa CDC together with the African Union Administration. There are two platforms, I think, which require support. The Africa Medical Supplies platform requires support. There is a work being now conducted in order to create a pooled mechanism for commodities and other supplies. Those will be the two important entry points for the case of Africa, coordinated by Africa CDC, to provide those resources to be spent locally. Because if Africa CDC really steered this process very well, the pooled mechanism, taking the examples from Latin America, this is a major example, a very good one, of the pooled mechanism for acquisition of commodities in Latin America is working perfectly and lowers the cost, ensures coordination, and gets the ownership of the process. I think this will be my suggestion. And the last comment, we have gone through the past. You, Catherine, mentioned the Lusaka declaration. Let's go back to the Paris. It's exactly the same thing.
I know.
Paris Declaration, Accra Agenda for Action, Busan conclusion, now Lusaka. There is nothing new. Mm-hmm. The issue is accountability and the proper governance mechanism. We fail there. And today, or this week, I don't know whether they reached an agreement with the pandemic treaty. It's that problem, accountability and governance, how that will be dealt with. Until we solve this problem, we'll get major hindrances, for the sake of time.
Thank you very much for your comments. Thank you. And right behind, just a brief question or comment, please, before we take it back to the panel.
Thanks so much. My name is Arish Lal. I'm a commissioner on the Commission for Universal Health at Chatham House and a final year PhD candidate at LSE. And my research is particularly looking at the integration of global health security and UHC. So what it really looks at, it's a political economy analysis of coordinating health agendas through diplomacy. And as we think about one thing I did not hear really in the panel is more of the existential threats that undermine these kinds of agendas and partnerships. In particular, we have faced rising authoritarianism that undermines the right to health in many countries. We're seeing a concentration of wealth that further constrains the public funds, and we're seeing rising threats from climate change and other issues. So as we look at things like Replenish or Perish and the way forward for partnerships, I'm wondering if the panel can reflect a little bit more on the broader threats to health, in particular how partnerships might navigate future threats. Thanks.
Okay, thank you very much. Panelists, you're very welcome to answer those questions or respond to the comments, whether it is about how to hold the boards accountable for their operational management through the replenishment or these broader trends that are impacting on the whole landscape.
I'm just going to start with the last question. One of the things that we were doing when we got to the Lusaka agenda was to understand the concept of mandate expansion in the GHIs. And what we did ask is what Justice just shared with us. Where are your statistics coming from? What gains have been made? And if you do some predictive modeling, will this still be useful 10 years from now, 20 years from now? And perhaps should we find another need for this resource? And some of the feedback that we got from the secretariats primarily was, well, our mandate is very clear and we'd have to go to the board, and then we'd also have to go to Congress and other countries to really expand this mandate. However, we believe climate change is very important. We believe, NCDs, mental health issues, are very important, and we know that they are linked to some of these conditions that we're trying to address. However, our mandate is sort of, directing us this way. In the corridors, what was clear is that the GHIs do understand that gains have been made, and that perhaps honest conversations need to be held on where this money should be placed, and that the biggest constraint seems to be where the money comes from and what the priorities are where the money comes from. Mm-hmm. What do I see happening in 10, 20 years? I think increasingly global health security is going to be an agenda in GHIs. I think we're going to have a folding in. And I think climate change will probably come into that space, but I think it's going to be a lot of struggle from where the money comes from to be able to make that case at Congress. Yeah.
Thank you. Yes, Anders, please.
I think the question around replenishment is interesting, and again, the title here. The term replenishment comes from IDA, from the World Bank. The way that things are done there, as you know, then you negotiate the priorities and the funding at the same time. We're not doing that anywhere else. So, we approved the strategy for the Global Fund and then we raise the resources. So, what would be ideal is that you actually, as a board, take responsibility for setting the priorities and ensuring the funding. That is what I've been arguing for WHO as well, that the board needs to take responsibility for the funding of the organization as well as setting the priorities. Today, you have delinking that, setting the priorities here, and then you basically, so replenishment is not a replenishment first. The Global Fund, for instance, or Gavi or WHO is not a bank, so you don't replenish the money like they do in the bank. So it's a wrong word, but they're using it more for resource mobilization. So I think it's an interesting discussion to have, but mostly from a governance perspective, who's actually responsible for not just talking or deciding on resolutions, or actually also ensuring that the organization has the necessary resources. That should be the governing bodies. I wanted then to just on the threats, because that goes back to what I was saying before, what is really affecting people's health. And we are not dealing with the major threats. Again, we have seen a decline on child mortality now down to 5 million children dying under the age of 5. Still an important agenda. But the big threat is the increased level of non-communicable diseases. The biggest threat we have to humanity today is obesity. And the food industry. Are the global health initiatives at all aware about that? Talking about that? No. That's not an issue because we believe that if overweight obesity, that is only for rich people. Or people need to blame themselves. That's your responsibility. It's absolutely not. Those are poverty issues. In my country, in South Africa, in the US, etc., it's the poorest people that are most at risk for underlying structural and economic reasons. But the global health community is not, they do not want to hear about that. So the biggest threat, I think, both is the mindset of us working in global health, but if I should put one threat on the table, it's actually what we're doing in terms of how we produce, consume, and waste food.
Thank you.
Can I briefly address the issue of coordination? I think parts of the first and the second questions. So at the country level, who should coordinate who? I mean, should it be the GHIs, Gavi, Global Fund, at the country level coordinating themselves? Or should it be the country coordinating them? I mean, I was with someone yesterday who was speaking about the CCM and asking, wait a minute, who actually sits on the CCM?
A country coordinating mechanism. Yeah.
Yes, who sits on the country coordinating mechanisms? There are, CHOs and other people who also have some interest, right? But I believe that the best way to address these issues would be to have a strong country coordination led by the country. Country-driven coordination. And I know that many will, okay, but some countries don't have the capacity to build their capacity if you want to. If the country comes together and has one plan, and my plan has a one approach to dealing with health systems, there are immunizations, there are HIV and all of that, but it's just one plan. Whoever comes fits into that. Because if we keep motivating GHIs to keep coordinating themselves at a country level, I'm afraid we are only creating country-level problems of the global problems. So what we need to do is to get the countries to strengthen their own coordination, not only at the health, but also bring in finance, bring in planning, bring in agri, bring in all of that to have one plan, one pot of money, and one way of monitoring whether that happens. This includes the donors and the GHIs at a country level. That may take time, but I honestly, personally do not see us solving problems, asking GHIs to coordinate themselves at a country level, if we don't put in some effort to strengthen the country-led coordination mechanism.
Okay, so One Health Plan,
Just
unless
going
you want to
back
comment.
to history, they are country coordinating mechanisms, they are not country coordinating committees. That was very deliberate when we designed the Global Fund. I was the interim executive director. I told all countries, use the National Health Steering Committee, don't create a new structure. Then this was in January 2002. At the World Health Assembly 2002, I had all the ministers in the room, and all of them came to me and said, why did you force us to create a new structure? That was how I failed in my communication. Was it only me failing? No, I don't think so. Because in countries, there were great interest actually to have a CCM. It was great interest to ensure that we safeguard the money for AIDS, TB, and malaria. It was great interest for the director for HIV to be able to control that money. So there were interest in the countries also moving not in the direction that you're saying, but rather to have it separate for a number of different reasons. But I agree, but then you need to have, and you have a few examples of very strong governments where you actually done this and you use those mechanisms. And what we have, again, if we go back historically, before the Global Fund, then we had what we called swaps, sector-wide approaches. And Ghana was one of the countries spearheading this at that time. And that was really about one plan, one budget, and that was the same. But it all comes down to national capacity, ownership, and political will, and prudence, I would say, also from Minister of Finance in countries.
Thank you very much. We have time for one more question. Sorry? One more question. One more question from the side here. You have a question? Oh, sorry. Yes, I thought you were communicating about something else. 2 quick questions then, please, and then here, Ellen.
Thank you. Carol Prashan, faculty lead here and also at the London School of Hygiene and Tropical Medicine, former board member of the Global Fund and worked in the Secretariat. Fascinating discussion and presentation, so thank you all very much. And it all, for me, seems to boil down to governance reform. And we've made many attempts over the years to do this. They have all failed because it's turkeys and Christmas, right? I was closely involved with some of the discussions just to get an extra seat for Africa on the Global Fund board. So what does the panel think it will really take to get serious governance reform? Because without that, I feel we are just tinkering at the margins.
Thank you very much. A question on serious governance reform. Ellen, please.
Thanks. Not a question, it's just we're having a very frank, wonderful, frank and punchy conversation today. I really appreciate it. So I thought I would add one more statistic of punch, which is we had an event last March about corruption in the health sector. And so, drum roll, yeah, at least 6% of total global health spending is lost each year to corruption. And we've been talking about transparency, but this hasn't come up in issue. People, you can listen to the recording discussion of our event. WHO head of governance unit that works on this topic was presenting these data. That's it.
Thank you for raising that. Francisco Sangane would like to comment very briefly, though, because we're running out of time. Do you have a microphone?
Oh, okay.
A quick one, Anders. I think we're not going back to 2002 or whatever. I will just address what Justice said about the importance of the country coordination. The issue, that is not new. It has been there. Your own country, Ghana, Mozambique, and Uganda, linking to the swaps Anders referred to. We had those systems mature, and it was working effectively. The problem is that through the GHIs, there is money, and it is the money that twists the mechanism that is in place. That you don't get the money you want, or you may get many players with huge sums of money, I don't mention names, who will refuse to put the money in the common fund, which was created by all the partners to put the money for the health program. That's the problem. If you get one partner who has got huge sums of money, saying, my money is not going to the common fund, you're lost. That's the problem. It's a governance and accountability issue. I think this boils down to that issue. Otherwise, we will never fix the problem. We'll come to with another initiative, with another convention, but we'll be back at square one. If there is no fairness and justice.
Thank you very much. Before I let the panel answer, and also that'll be your final remarks, Antoine, maybe you want to also answer the comment about your presentation.
Yes, and thank you for your question. I think just very briefly, I wanted to say that my point about inter-PPP cooperation was really to say that there was a precursor to the access to COVID tool and accelerator. It doesn't come out of nowhere. There's been efforts to coordinate before. But of course, when you look at what happens in practice, it's still very much siloed. And I thank you for bringing up the health system strengthening bit, because if you look at the indicators upon which these GHIs operate, to implement health system strengthening, it's extremely targeted, and it's very few of them. And so it's still each, selective primary healthcare. It's not comprehensive universal health coverage. So of course, there's still huge gaps in terms of cooperation. And I didn't mean to come across as saying that the problems are being solved. I just meant that there were steps ahead of the pandemic that laid the ground for what happened during the pandemic with the creation of ACT-A. But thank you for your remarks.
Thank you, Antoine. Okay, panelists, in 30 seconds each, please address these huge questions about everything from corruption to what will it really take to reform the agenda?
30 seconds is short, but I'm just going to make it a little bit more difficult and throw another bomb, as she's just done on corruption. Kenya right now is going through its budget cycle, and all ministries received cuts, including health. Roads received cuts, education received cuts. And right now, all the income that Kenya is generating, 70% of it is going to debt. 70% of it is going to debt. Kenya is due for graduation from Gavi in the year 2029. That's the reality on the ground. So while I do agree with sunsetting, and I'm a champion for that, we're going to have to also look at the reality in countries, in ground, and get all this data and information to sort of figure out what would improvements look like. I think have an eye out for Lusaka Agenda. We'll be in Addis in June, I think, in about 2 weeks' time, to be able to ratify this through the AU conventions and have ACDC play a key role. So there is hope. It might not be like Paris. Let's see what happens at the Africa CDC taking some center stage in this work. Thanks.
Thank you, Mercy. Anders.
I mean, my feeling after listening to this is that money is the problem. Money is the poison. Money is what destroys things. So I think we need to think a little bit about what we do about that. The other big thing, the element we haven't spoken about when you speak about debts, that's China. Yes. Most of the debts today in the world is with to China. And what role is China going to play in the future when it comes to also supporting and working with countries on health? They've traditionally been investing in infrastructure. I think they are thinking differently now. So I think that's what also been interesting discussion. Finally, just one around the health systems platform. I don't know how many working groups, etc. I've been chairing on health systems for Gavi, the Global Fund, etc. That came out of a piece of work that we did on innovative financing, co-chaired by Gordon Brown and the World Bank president at that time. There were 3 partners in that, the Global Fund and Gavi, as you said, but the third one, and that was the partner that pulled out, that was the World Bank. And that was why it failed.
Thank you.
Thanks for bringing up the issue of debt. I'm an economist, and perhaps lucky you are spending 70. My country is spending more than 80% on debt. Should that be an excuse? No. If you look at the economic systems, debt is a cycle. It's a cycle. It goes up and comes down. We need some bold decisions. I mean, I don't call back my proposal to sunset. I think we need to really be pushing on some of these things. Corruption is important and has to be addressed at a country level. But tell me which other country doesn't have corruption? Corruption is everywhere. It's not an excuse, but we have to deal with it. Finally, so on Sunday night, I was in a room, where the African ministers of health debated for over an hour, discussing what their common position would be around the pandemic treaty. Learning from countries, sometimes not shutting people down, but really aggressively. They did come to a position, and I wasn't in the discussion yesterday, but largely what I hear is the position that African ministers came to. They agreed on what they call the common African position for the pandemic treaty. And I think one way of really pushing some of these GHIs is having that kind of a position, what Francesco has said. You cannot have one minister going to sit on a board, and the others don't even know what he's going to say there. There has to be a position, and that position would put some form of not only pressure, but makes that person obliged to really say not what he wants, but what the countries want. So I think we need to strengthen that kind of a regional mechanism to put some more accountability on the GHIs. Thanks.
Thank you very much, Justice. So just to wrap up here, we have discussed some of the governance challenges that have emerged as global health partnerships have become more powerful. But also, I think as this discussion is ending, it's a window onto broader issues, whether it be money, corruption, debt, or geopolitical shifts, which will surely shape how this plays out in the future. I think, listening to what you've said, I think that it's clear that incremental change is not really what we're looking for here, and that we need a much more ambitious agenda going forward. And perhaps we should be looking outside of the partnership model rather than inside it to help us define our future priorities and approaches, and then look at whether partnerships are a tool to achieving those priorities. But I think, although we're talking about, what's changed, we've heard all of this before, et cetera, I think one thing that has changed is that we are able to sit here and have quite a frank discussion about the challenges, on the sidelines of the World Health Organization and with a great audience. So I just want to end by thanking you all for coming and engaging in this important discussion, and also to the Graduate Institute for allowing us to use this as a platform for launching it. And before I ask you to help me thank the panelists for their wonderful contributions, I'd like to invite Professor Suri Moon to give some concluding remarks before we wrap up. Thank you very much.
Hi, everyone. I'm going to be very brief indeed, in the interest of getting us to the reception more or less on time. I also really appreciated the frankness of the discussion. I do think that oftentimes in the global health community, we don't make space and we don't have the courage, in fact, to ask the hard questions. So I really thank our panelists. I thank the participants for your frank comments and questions, as those of you here in the room, those of you online. I think Katrini has done the hard work of actually summarizing some of the key takeaway points. Thank you. So I'm not going to spend time on that. I'm going to spend my time instead on thank yous for making this conversation possible. First, our thanks to, as I said, our speakers, our participants, to our partner, the University of Oslo Center for Development and Environment. I hope we can have many future discussions on this question and related ones. I also wanted to flag that the recording, as you heard, will be available on the Geneva Global Health Platform's website, where you can also sign up for our newsletter if you would like to indeed participate or propose future topics for discussion, which is ghplatform.org. And I want to thank indeed our team for making this possible today. We have here Ellen Ruscom, Bettina Zago, Erika Scheinerberger, Thomas Morokovich, and Moin Hossein Alipur. It takes a lot of work to put together these events. And I'm very delighted to invite you all to continue the conversation at the reception upstairs, just upstairs. So with that, thank you very much.